Brownsville, Pharr, Edinburgh, Mission, McAllen, El Paso. And obviously these counties obviously encompass many more cities than they do. So Hidalgo encompasses all of these, most of these places here. And then clicking through, here we go. And then there's other cities and other counties that encompass about over 50% of their population speaking Spanish, and they're highlighted here. And what was really telling to me that the counties of Hidalgo, Bexar, Dallas, and Harris, only those 4 counties accounted for nearly 7 million Spanish speakers. And I was freaking out. I was like, they look so small. I know population-wise they're not small, but that is a huge number to encompass 7 million speakers in these areas. And obviously they're dispersed far more and far greater in the Texas area, but those are the highlighting points of the state of Texas. It's very impressive and very incredible. So there's 40 million plus people in the United States who are speaking Spanish. 7 million are located in the great state of Texas. So what do we do? The answer, of course, isn't as simple as become a Spanish-speaking audiologist. I feel like if it was that simple, I wouldn't be here. Sarah wouldn't be here, and we wouldn't be having the struggles that we do on the daily. And like we mentioned before, the 2017 ASHA data suggested that bilingual audiology and speech providers only make up 6% of their population, and of their population, 4% are Spanish language providers. So it's not a lot. Of course, like I mentioned before, a big disclaimer is that this is not a reflection of just true audiology, although there are audiologists enrolled in ASHA, so it is a reflection of some of them. But AAA, which is a governing body for exclusively audiologists, doesn't collect that demographic data. However, this data for speech language pathologists is a really big deal because we know systematically there are a lot more SLPs than there are audiologists. So if there's only 6% of bilingual speech therapists, we can only kind of imagine that our audiology statistics are pretty close, if not less. We can make that assumption. That is an assumption, of course. There's not foundational data on there, so don't quote me, please, like Sanchez et al., and then be wrong. It's not peer-reviewed or anything. So our clinic, and I'll briefly go over this. Becky was like, do not talk about your clinic here, but I do because it's fundamentally why I do what I do, and it's really just to give you a picture, just kind of how I showcased Texas. This is where we're located in the little southern tip of Florida, not the southernmost county, of course. That would be Monroe. That encompasses the Keys and this Everglades area that nobody lives here, but they do live in the Keys, of course. But our clinic, we have actually 3 clinical locations in the Miami-Dade County, and then we have 3 additional clinics in the Tri-County area. That's what we call that in South Florida. That's people who say they're from South Florida usually consider themselves from this area. I found that in my life, people either are from South Florida or they're from Miami, right? Like people from Miami don't say they're from South Florida, but people who are not from Miami but are in Palm Beach, so they say they're in South Florida. It's a good delineation to see where someone is from. It's a good checkpoint. If you're like, oh, where are you from? They're South Florida. You know they're probably not from Miami, but they are still in the South. And there's a big saying about Florida, right? The more north you go, the more southern it gets culturally. So as we get closer to Georgia and Alabama, our Spanish-speaking population reduces probably significantly. Our clinic actually caters to this area, this geographical area, including the West Coast. Our West Coast really lacks a lot of pediatric services, and so we see a lot of patients driving up to about probably routinely 4 hours to see us, which is nuts. And that's for regular routine cochlear implant mapping, or so to speak. This line here, though, is pretty much this imaginary line is really just delineating the Orlando area. Once you get to Orlando, there are a lot more services that are provided. So people who live north of here usually tend to go to Orlando or into Gainesville, which is where University of Florida's clinic is. Our providers, we have a lot of audiologists. All of them are here. We have an audiology extern and an audiology fellow. Who is actually someone who is fully graduated, has their AUD, but is taking 1 year to focus on implants and pediatrics alone, to garner just experiences there before they get a full-time position. And then we have members of our multidisciplinary team. The Children's Hearing Program encompasses actually we have 2 psychologists now, 2 auditory verbal therapist, a social worker, and an educational specialist. Of all of the people who work with patients who have hearing loss, 56% of us are bilingual, Spanish speaking. And I do like to highlight that our entire multidisciplinary team is bilingual. That's imperative to our multidisciplinary team in regards to providing intervention. 22% of us are trilingual. Our team encompasses people who speak multiple languages, but including French, Arabic, Italian, Portuguese, and sign language. And while this looks pretty impressive, and if you look at the data and how Sarah suggested that we're hogging all the Spanish-speaking providers, that may or may not be true, but I will say, as a testament to myself, I am the only pediatric provider who speaks Spanish in our clinic. So of all these people in color, I am the only one who sees children. So that's really not fair, but but it's still a testament to we do have a lot of bilingual providers, and we are probably hogging them, but it's not my fault by any means. And more importantly, our staff is really important to us because they're really the gateway of making appointments. You know, patients need to build rapport. They need to feel comfortable talking on the phone and just creating that appointment, that initial setup. So we have 2 pediatric administrative staffs, 1 clinical coordinator, 2 cochlear implant admin staff, and 2 hearing aid admin staff, all of which speak Spanish. And then we have clinical assistants. Our pediatric clinical assistant, her hair is no longer blue, although we did love it when it was blue. We have a hearing aid clinical assistant, a cochlear implant clinical assistant who has implanted herself bilaterally, and 2 just diagnostic and other specialty clinical assistants that help run our ENT clinic. And of our 15 staff members, 100% of them are bilingual, and 9 of them are interpreter certified. So you can imagine what a big help that is in a clinic that sees, 80% of our population is Spanish speaking. And if we polled actually our bilingual providers and we talk about like their caseload and what they have been seeing, 75+% of their caseload is Spanish speaking. In fact, I just pulled one last month for myself. I saw 147 patients and 129 of them didn't speak English, which is huge. Of that, 119 spoke Spanish, and then the rest were down here. 88% of my patients were non-English speaking. Makes it hard for me to have students with me, but we try to do what we can. I serve as their interpreter if that's the case, to help facilitate that kind of communication. And then our international reach, like I mentioned before, so I'll briefly just go over this. This is kind of our international blueprint or our footprint, I would say, and mostly because we have this little geographical hub where we're just on the tip of the United States. So patients have very close proximity to us. We're very thankful for that opportunity for sure. So that was just a brief review on just language diversity highlights. I didn't want to talk too much about that because that's just census data. It's just kind of more just routine data. But we did talk about the dispersed variety of languages across the country and how they compare to languages across the world and where these people are located and why they need our help. Before we move on to our next section, which is going to be cultural competency and respect, does anybody have any questions? Anyone in the chat? I don't think so.
No questions in the chat.
Perfect. So we will move right along. So we did briefly talk about this, but I do want to dive in to a lot of this because I think it's important to understand, and it's really something that it's not even a skill set at this point. It's something that must be like innate as a provider when you're seeing these patients who speak Spanish. So what does it actually mean to be culturally competent? We can read the definition by and large, but they're really just it takes so much of your being to really put yourself aside from your own thoughts, whether they're biased or not, to be culturally competent. It is defined as the ability to understand, communicate with, and effectively interact with people across several cultures. And encompasses being aware of your own worldview and aware of your own culturally learned assumptions, some of which may be biased, and that's okay. It's what we've learned. These are learned biases, and we have to, I think being culturally competent means that we have to be self-reflective and understand that what we've previously thought may or may not have been biased. It encompasses developing positive attitudes towards cultural differences and gaining knowledge of different cultural practices and worldviews. It also encompasses developing the skills for communication and interaction across cultures. Cultural competency competency by and large is not static. So you may have a cultural competency for one culture, and that may change. And our level of cultural competence changes in response to new situations, new experiences, new relationships you make with people who are from different cultures. And the Hispanic culture is very telling of that because, like we've alluded to at the beginning, you meet somebody who may be of Cuban descent, and that may be a very different experience than you meet with someone who may be of, Venezuelan descent. And that's not any critique on either Cubans or Venezuelans. It's just that we also share, even within our Hispanic culture, share differences, not only in dialect and, but in every aspect. We're very different. So it doesn't do any justice to reduce us to one group and just say, all Hispanics are XYZ. Because that's not true either, of course. There are three fundamental elements to kind of achieving cultural competence, and they are having awareness and attitude, having the knowledge, and having the skills. So we're going to dive deep into what these three things really mean and how they apply in the clinic. So the first talking point is awareness. So awareness. Awareness is when we move from being culturally unaware to being aware and or sensitive to our own cultural heritage and to valuing and respecting differences. So this is just really more, I think of this as like self-reflection. You're really just aware of where you've come from, where your family has come from, and you understand that there's differences. We are aware of our own values and biases and how that may affect others. We're comfortable with differences that exist between ourselves and others, whether that's through race, gender, sexual orientation, or other socio-demographic variables that may be different from ours. And we're also sensitive to circumstances that may dictate referral to patients to members of their own socio-demographic group. And lastly, we're aware that of our own racist, sexist, heterosexist, and other detrimental attitudes, beliefs, and feelings. So that's not me calling everybody here racist, sexist, heterosexist, but it's just being reflective of our previous biases, if we've had any, and how it relates to the culture that we're trying to engage with. What I wanted to bring home here is this line here. Being sensitive to circumstances that may dictate referral of patients to members of their own socio-demographic group. This happens quite often in our clinic, and it's nothing to take offense to. I think, especially in the Hispanic culture, communicating through an interpreter is going to probably yield to probably a less satisfying experience than having a provider who is truly bilingual. That is to say that using an interpreter effectively is far superior than not using one at all, or using one through like a broken telephone line. And so I'm not saying using an interpreter is bad, but these patients are making and developing their experiences based on not only the severity of the condition that we're diagnosing their children with, but also on the pretense that they want like minds gravitate towards each other. So it shouldn't be too uncommon if you want somebody who's maybe shared your experiences prior and wanting them to be involved in the counseling and decision making of that experience for their patients and for their children. So a lot of times in our clinic, we definitely see children who may be diagnosed by some patients and then they transfer onto my schedule, or they remove themselves from my schedule. That's happened too. And it's mostly because either our provider has recognized that our providers are culturally aware, and they think that maybe, so oftentimes it actually happens more often than not that it's another provider who has this cultural awareness to be like, I don't think the message is getting across very well, or it seems like we're not clicking, or it seems like we're not understanding each other, even though we have a clear understanding of what's being said. And so I think that this may be, let's try with a Spanish speaking provider and see how that relationship flourishes. And that's usually a mutual agreement between both the patient and the provider. On the other extreme, it could just be the patient's request, and we always just try to abide by that based on schedules if we can. Of course, we always give patients the option. But by and large, that's usually what happens. And so sometimes it's not to take offense to what their preference is, but I think it's mostly to be aware that sometimes you may just not vibe or clash with a certain person, and it may not be because of your personalities. It's just because your cultural differences. And that, I think, is the stepping stone of being culturally competent. It's like the first base step of getting there. The next step is called having cultural knowledge. So we are knowledgeable and informed about culturally diverse groups, especially those we are most likely to work with. So we actually take that effort to learn about these cultures. I do this a lot with my colleague who is Muslim, and I love to just learn about what holidays she celebrates and what the etiquette is. And we actually, making this presentation, she was like reading some of my slides, and we actually found out that the Arabic culture and the Hispanic culture are actually very similar in how in child rearing, and specifically to child rearing, of course. And it's just so interesting because obviously you become more interested and you become more knowledgeable with the relationships that you make with others. Would there be any other compelling reason to become more knowledgeable about these cultures? Maybe or maybe not. That's a personal choice for you, of course. But I think the more culturally diverse you make yourself, and the more knowledge seeking you are, the better you are actually understanding your patients and where they come from. And not just in that, and that obviously comes with the extreme of not generalizing or overgeneralizing the experience of one person and associating it with everybody else. You're knowledgeable about social and political factors within these groups that may influence how treatment is decided. This I thought was an interesting point, and I think of, you know, this is irrelevant to audiology, of course, but I think of how my grandmother is a hoarder, a food hoarder. And every time I go to her house, she has containers of these non-perishable foods, and I'm always like, Abuela, why do you have 18 gallons of rice? And she comes from Cuba, which is a communist country, and from one day to another, everything was taken away from them. And now she's just developed the habit of just like buying things and keeping it just in case something were to happen. She's got a bunch of rice and canned food, that's for sure. But it's like always alarming. I'm like, what are we saving up for? Like, and it's just something that she just habitually has developed. This is part of her character, her personality. And she always like, hi, you don't know what I went through. And I was like, so we try not to dabble into getting her emotional about it, but it's just an interesting thing about the political factors that these people may go through. I also think about the time that I saw a patient from Venezuela, and they were an international patient, but quickly becoming not an international patient. And so we always ask, as just full disclosure with our international patients, like, when are you going back home? Not because we don't want you here, but it's always because it's like, oh, we're leaving in 12 hours. And we're like, oh, you want us to get you a cochlear implant in 12 hours? Oh, okay. So it's really just to have a realistic timeline of when these families, their traveling schedule is. And I vividly remember having a talk with one of my patient's fathers, and he wanted to make sure that she was actually off the air. We were programming her cochlear implant, and I asked him just coincidentally while she was off the air when they were going back to Venezuela, and um and he was like, is she off the air? And I was like, yeah. And he's like, we're actually not going back, and she doesn't know that, because the political status of Venezuela was so bad that he's like, I fear that if we go back, they're just going to take everything that I've heard, all my hard-earned money. And he's like, it cost $27 to buy a gallon of milk over there. The political climate is so negative over there that he's like, I think we can get by just staying here for a while. They have extended family here. But he's like, but she doesn't know that just yet. And so you can think of like how traumatic that may be to these children who are coming for their routine appointments and realizing they may not go home. And that kind of hit me a little bit. I was like, oh, and he was emotional about it, but he was hopeful, because I think it made him feel better knowing that there's probably a brighter future with the resources he had here than going home. And that must be, I often think about what decisions he was making as they were packing bags, just to come for what they thought, what his family thought was a routine appointment, which they've done. The child is 8 now, and she was implanted at birth. So for the last 8 years of her life, and knowing that she wasn't, and having that conversation with her, which was obviously out of my realm. That's not something that I had with her, but I can only imagine the hardship that they felt having that conversation with her, and them having to make these decisions based on just simple political factors that are happening in their own country. We're knowledgeable about the institutional barriers, such as racism, that prevent some diverse patients from accessing services, privileges, and advantages. We talked about this earlier, just not even having these resources that are in foreign languages will prevent people from seeking healthcare. And that may truly be the deciding factor on whether a family will choose to even join this journey with you. I always talk about, people always talk about, when you diagnose hearing loss, it's like a journey. You're guiding them on their hearing loss journey, and it's like a roller coaster. It has a lot of darkness and it has a lot of sadness, but then it has a lot of good times too. But some of these things, like, you can't even address this journey without even breaking down that institutional barrier of them feeling like they're not even included, or they're not even, they're not even thought of when you give them a brochure that's just in English and you're like, sorry, and we talk about that even in the school system. They're given an IEP that's not even in a language they can read. And, it's just going that extra step when we know that IEPs, from our deaf educator, we found out that IEPs can actually be printed in like 36 languages. I didn't even know that, but she was like, it's just a matter of printing it in a different language and just making that extra effort. A lot of like softwares, when you print reports, have the ability to just change the language, and that can mean just so much difference for these families. And then the last kind of level of cultural competence is having the skill set. So we are able to generate, sorry, I'm going click happy here. We're able to generate a wide variety of verbal and nonverbal culturally sensitive responses. We're able to communicate accurately and appropriately. We're able to anticipate the impact of our service delivery and our limitations on cultural diverse clients, such as the language spoken. And this also ties to my colleagues, where they definitely do their best. And then when they're like, ooh, I have to do some Spanish testing with this patient, it's going to be a lot easier if Chrisi does it than doing it through an interpreter. So knowing your own limitations, because it also can be that you don't want to be so overbearing and being so excited, being like, I am so passionate about working with other people that I don't speak their language, that you don't want to hurt them at the end of the day, being like, well, I don't know how to test them, but I'm still really passionate about helping them. There's a kind of that line that you need to understand within yourself of knowing your own limitations as well. And we're able to communicate in an easy to understand language that's linguistically and culturally appropriate when working with diverse colleagues and patients. I know that Miriam, who's in this group here, is very passionate about literacy. Not to shout her out, but she obviously she works for Medell, and she's one of the leader of their bilingual
program.
And she's also someone who while I've had the pleasure of working with Miriam at University of Miami, working with her very clearly made us aware of literacy, and just understanding that education of your clients or your patients, and understanding that not only just a level of education, but we just phrase things differently. It's not as high tech, not as quite just anatomical. You don't call them the ossicles, you may call them the huesitos, like the little bones. It's just, you don't call them hair cells, you call them pelitos, the little hairs. And it seems like, wow, you call them little hairs, and it seems like a lower education, but it's beyond just the lower education. It's just more about a literacy, a true understanding of, you want them to understand the nature of their hearing loss. And I am, for one, someone whose knowledge is power. I'm going to give you the fundamentals, and I'm going to show you where this hearing loss is derived from. And if I have to say that, oh, it's the pelitos that are the ones that are damaged, then so be it. I'm telling you that the pelitos are damaged, or it's the huesitos that are damaged, or I don't know the status of the huesitos, because I don't, because your child has microceratresia, so you're going to need a CT scan, which is an X-ray. We don't talk about it as a CT scan. We talk about it as an X-ray, and your child needs an X-ray to see the status of the huesitos. And so this is really just all about, health literacy in the end of the day. Oh, yep. Becky, health literacy. Assume the information is difficult for everyone and make it easy for them to understand. Things like they talk about this a lot with the capital D deaf culture too, that the average reading level for a capital D deaf culture is about third grade. And so you think about that, and I think this is just probably a general rule of thumb of working with anybody. It's probably going to be better if you dumb it down for everybody, because it's going to be easier to understand across all cultures. I think that's just my rule of thumb. Correct. It's not about showing how smart you are. It's about elevating understanding. I think everybody here understands that we have our degrees, we have our doctorates, we have, and that's really the challenge, right? You have a doctorate level understanding of something that you have to break down to a third grade level. That's probably what makes you truly a doctorate, right? Is your ability to be like, I fundamentally understand something so well that I could break it down and explain it to a child, and they would understand what I do for a living, which I try to do with my nieces every day. I'm almost there. Some of them still think I'm a surgeon. I'm like, no, I don't do surgery. That is not what I do. So moving on, let's talk about the Hispanic culture. This is where we get to the nice, like, nitty-gritty of things. So let me see here. Sorry, I'm moving the screen here. Before we can address barriers and differences, we need to understand what fundamentally makes this culture so unique. And we briefly touched these things in the earlier thing, but I'm going to go deep into them. Okay, so the first thing we're going to talk about is family tradition. And I'm going to highlight the probably uncomfortable roles of machismo and marianismo roles. We're going to talk about religion, and we're going to talk about etiquette. Ooh, it's going to be exciting. So first things is La Familia. La Familia is just the most important social unit to Hispanic families. It's a unit that extends beyond immediate families. It includes the extended family, like my average family party. Actually, don't even have any first cousins, but the average Hispanic family has several first cousins. And I think of, but I think of my second and third cousins as my first cousin. Everyone is a cousin. I think of people who are probably not even cousins as cousins. Like someone who probably should be a tío or a tía is probably a cousin, or like a friend that I've grown up with my whole life I consider a cousin. Is I don't know if that happens in other cultures, but everyone is a cousin for me, whether they're blood related or not, and they're always invited. The door is always open. You know, this is what this culture has, an open door policy. Your friends are hungry, they're going to come and eat, because my mom always have a arroz y frijoles in the fridge ready to be, you know, to share. And this is kind of the foundation of this culture. It's so far beyond just the mom, the dad, and your siblings. It's extended to everybody. Like we said before, abuelas and abuelos, the grandparents often live in the homes with families, if not very close by, if not across the street, if not in like the efficiency that you've attached in your house. Um, Yes, Mariana, where your madrina is still your aunt, that is for sure. Your godmother is also your aunt. And so, you know, like the relationships are also blended, but it's wonderful, and it makes it that much more unique and special. And you know, it's just it's your godfather. You're right. My godfather is also my uncle. So like, yay. But it's so true, and you don't even think that it's abnormal until you probably start talking about it, and people are like, "No, my godfather is not my uncle." I'm like, oh, okay. To each their own. You know, I think, but it's also probably the consequence of living in our Miami bubble. But the Hispanic culture is just so warm and welcoming, and all that is to say that there are definitely definitive roles within the Hispanic culture. We are tightly knit, and there's a sense of moral responsibility to aid other family members who may experience financial problems, unemployment, health conditions, or other issues. This is something that a lot of people say that, like, it's funny in the Hispanic culture, like when something happens, the whole family knows instantaneously. It's like everybody gets on the phone and they start talking about it. And part of that is because everybody cares, and everybody's going to come, and you're going to, you know, you go to the hospital and it'll be like, people you've never seen, you haven't seen in years, they're showing up with like flowers and probably soup ready to give you at the door. They'll send you a card, or they'll send a card with another cousin with you, and you're like, wow, I haven't even heard. But it's really when times of need, the Hispanic culture really comes together, and there's just that sense of responsibility. You're not going to let somebody kind of suffer on their own. The father in the family is usually the head of the family, usually the decision maker, usually the bread maker. The mother is responsible for the home and largely for the children. And this is obviously true to what we are fundamentally talking about. Preserving the Spanish language is probably one of the most important Hispanic values from a Spanish speaking home, and it's common practice. It is often the reason why a lot of us are primary Spanish. We are first Spanish speakers first, and then English speakers second, is because the concept of learning English will happen at school, but your fundamental Spanish learning happens in the home. And I know that people were in the chat about this in the earlier talk about how, you know, I think someone's husband mentioned that, you know, at home they spoke Spanish and then at school they spoke English, and that's very common practice for many children growing up in Spanish speaking homes. And then a lot of times it gets blended and it turns into Spanglish, which is always fun. I think that I'm professionally fluent in Spanglish, I would like to say. It is now my number one language, followed by English and Spanish. And so you see, my first primary language was Spanish, but I have two other siblings who are older than me. And so you can imagine that my sister, who's the oldest, got exposed to full Spanish. And then my brother came and he was also exposed to Spanish. And then when I was born, my siblings were school age. So they started implementing more English in the house. And while they still fundamentally tried to teach me Spanish, I was already like, I was probably born into the Spanglish world. But all that's to say is like my grandparents and largely a lot of my cousins are exclusively Spanish speaking. So preserving that language is important. It makes you a part of that family unit. It's integral. And there's also this association as the generations become more cultured to the US, preserving Spanish becomes much harder. And that's true because more people in these US households are speaking English. So like my parents who were born in Cuba, they speak perfect English, and we speak English in the house. When our grandparents come over, we all switch to speaking Spanish, of course. But my nieces, who are obviously a generation beyond me, I remember my niece Chloe, who is now 10, but when she was really younger, we tried to exclusively speak Spanish to her, and she would always respond in English. She knew what we were saying, but she responded in English. And she broke down one day, and we're like, "What's wrong?" And she said that she didn't want to learn Spanish because that meant being old, because she associated all the old people in our family only speaking Spanish, and she didn't want to be old, so she didn't want to learn Spanish. And that was just a funny stage. And now, of course, she's in a dual language program in elementary school where she half of her curriculum is in English and the other half is in Spanish, and it's brutal, but needless to say, she's improving on her fluency in Spanish and is not fearful of growing old at the same time. We got to work on the little one now. She's 4 and in trouble. But part of the familial roles includes this understanding of the machismo and the marianismo roles. The social cultural scripts of male and female gender role socialization in Hispanic cultures are often referred to respectively as machismo and marianismo. And I don't know about you, but oftentimes when we talk about machismo or machista, it usually has a negative connotation to it. And I'll explain further why. But machismo, by definition, describes beliefs and expectations regarding the role of men. It's a set of values, attitudes, and beliefs about masculinity or what it means to be a man. It encompasses both positive and negative aspects of masculinity. So it encompasses bravery, honor. It also encompasses the dominance, aggression, sexism, and reserved emotions, amongst others. It includes the attitudinal beliefs that consider it appropriate for women to remain in traditional roles, encouraging male dominance over women. This is something that I feel like, while you personally may agree or disagree with, is almost irrelevant to the fact that you can't turn your eye to the fact that this does happen in a lot of just newly generational families of Hispanic culture. Less does it happen to more US accultured families, and more does it happen to families who have much more ties to their native country, or they still have more family members living in their native country, and they're first or second generation families in the United States. Traditional machismo is often associated with negative aspects of masculinity. So that's when we refer to somebody, oftentimes a father figure, as a machista. This happens a lot in our clinic, and it's not an insulting term by itself. It is truly a descriptive term, and we use it a lot when we're discussing cases amongst each other, and you're talking about, why was dad not approving of this, and you'll ask amongst each other, like, what was dad like, and someone will say, well, he was very machista, and immediately someone will know exactly what you're referring to when you say that. The more positive images of male gender role characteristics, such as chivalry, bravery, family provider attributes, are now more often being considered as caballerismo, like a caballero, a gentleman, while the traditional machismo roles are kind of left to more negative aspect. Like I mentioned before, additional research supports that traditional machismo may be influenced by factors such as acculturation, that is, the endorsement of this machismo role and the acceptance of this actually happening in a family is higher amongst individuals with lower US acculturation. And it's probably telling, I know with my own patients, I see dad more involved in the more acculturated that group is. So maybe my younger families who are probably first or second generation Americans themselves, but maybe were not born in their native country. That's usually when we see dad come into appointments, especially with therapy as well. But those patients who maybe just recently moved to the United States, or their child is their first generation American, you often see the mom being the primary person coming to appointments. You may meet dad at the diagnosis, at the hearing aid eval, at the cochlear implant eval, and then after that, you don't really see him in the picture. That doesn't necessarily mean that he's not around. The counterpart to the machismo role is Marianismo, which concerns traditional female roles. This emphasizes the role of women as the family and the home-centered, encourages passivity, self-sacrifice, and chastity. The Marianista, which is how we would refer a female, such as machista being the male, Marianista being the woman, it depicts women in nurturing roles and prescribes respect for patriarchal views. Again, whether you believe, support, or refute that kind of role is irrelevant in the concept of understanding that it does exist and it is very real for some of these families. So how is this relevant? Well, largely it should be fundamentally structure how you diagnose hearing loss and counsel families, recommend treatment plans, and onboard them to their hearing loss journey. I think these are understanding family dynamics is really huge in the diagnosis part of this. And we alluded to this early, but it's fundamental. You really need to consider that if your mom is bringing the child and your father is not always attending the appointments, you want to think about her level of education and IQ, right? The mom is receiving this information, and while she may be the main caregiver, is she the decision maker? And I like this. I like this example that I'm about to give. In about 3 weeks ago, I saw two children with autism spectrum disorder back to back. One coming from a Hispanic family and one coming from a Caucasian family. And I made the same recommendation. I was not having it was not good. It was not a good audio day for me. They didn't want to be touched. They were screaming. It was almost like the same identical child back to back. And if you've been there, give me like a clap or something, some reaction to know that I'm not the only one who's been there before. And it's one of those days where you have like that blank audiogram, like, come on, who feels me? That you're like, man, I spent an hour with this kid and I got nothing. I can't even get a timp. Like, woof. Yeah, I know people feel me on that because, and I often, it's actually interesting. We talk to our neuro-otology residents a lot. About this part because they don't understand, and so sometimes they'll see the patient after us and I'll give them the blank audio and I'm like, good luck, and they're like, what did you get? And I was like, nothing. And they're like, but didn't you just spend an hour with them? I'm like, I sure did. And and they just don't quite understand until you're like, well, next time they come, I encourage you to join me in the booth with them, because it's just screaming, or it's screaming or it's fighting. And maybe I'm not, when I'm adamant about could not test, it's not these kids that I'm talking about, to be clear. It's not could not test for Spanish, but the kids that have sensory integration issues is a whole other beast in itself. And then when they have sensory integration issues such as autism plus hearing loss, when you have that hearing loss plus population, that's when you're in for a doozy. But these kids, of course, were both coming in with, as you may expect, a speech delay. That's what they usually always come in for, and to rule out hearing loss. And I'm glad that I can share that experience with you guys. I was really happy. I actually turned on the video so I can see people like, yeah, makes me feel less alone, honestly. So sometimes an isolating time when you're with them. And so back to my caseload, we have these two children with autism spectrum disorder. I've tried for an hour, I failed, an hour, and I failed. And I made the same recommendation. They both came with their moms. This was recent, obviously, because with COVID, only one caregiver is allowed with a child unless there's a nurse needed or a therapist needed for whatever reason. And so this is this Hispanic mother who I'm counseling, and I make our ABRs, unfortunately, well, not unfortunately, I shouldn't say unfortunately, we don't have the capacity to do ABRs under sedation. So our ABR option is under general anesthesia. The benefits of general anesthesia, aside from the anesthesia, of course, is that they're always linked with an otology appointment, meaning they'll get a really good ear exam. If their child has fluid, they'll put tubes. Like we can take care of multiple things at once. They need adenoids out. The negatives, of course, is if we're truly just concerned about hearing loss, unfortunately, this child will have to be subject to anesthesia to get the ABR done. We don't have a sedation suite at our disposal. Our local children's hospital does, but that would mean that they'd have to go establish care somewhere else. So it is a little tricky for those families. So I talked about the nature of getting an ABR under anesthesia. I talk about, and my counseling approach, maybe that's because I'm Latina myself, is always like, I understand that you may need to talk to your family in order to make this decision, which is probably a biased maybe recommendation I make to all of my families. But I always err on the side of maybe they have someone at home they want to talk to. And maybe that's because I've grown up with this Hispanic culture of like, we make decisions as a family. And so I always say, I know you may want to go back to talk to, and I'm talking to just mom. So I understand that. I'm like, I understand you may need to talk to some other people and make that decision. And you're right. She says, yep, I'll get back to you, because in reality, she's got to talk to her husband and probably the grandparents, abuelo and abuela, and maybe the other kids that are involved in this family, talking about how the little brother is going to have to go under anesthesia. And we're going to weigh the positives and the negatives about this situation in order to make this diagnosis. And in order to not make the diagnosis, but kind of make the first step in order to get a diagnosis, of course. And then right after this, I had this mom come in. And, I said the same thing. I understand you may need to take this recommendation back with your family to make a decision. And she's like, nope, I'm making the unilateral decision. We are moving forward with an ABR under anesthesia. I'll talk to my husband about it later. And I was like, okay, wow, I don't even know how to move forward with that. Because like, who do I talk to now? Like, I'm so not used to parents being like, let's do it right now, that I'm like, okay. So she's like, so what do we do? And I'm like, good question. And I go and find a surgery scheduler, and I'm like, hey, we have an ABR that's ready to do it as soon. And mom's like, can we do it like tomorrow? And I was like, well, I don't think we can do it that fast, because you have to get a COVID test. But so it's just truly, it was truly just a reflection of just cultural differences. And it's not like this lady was like, no, I'm going to talk to my husband about it. But if he doesn't agree with me, it doesn't matter, because we're moving forward with it. Whereas like that would probably never happen on this side of that experience. And so it was a unique thing that happened back to back. And it was so telling for me that I was like, wow, this is truly just a cultural difference in how we're making these suggestions and recommendations, and how decisions are made for children, on the spot versus let's chat about it and take some time. So the next part is, we talked about family and family involvement, and how, family is very important in decision making, especially when you're making a diagnosis. But now we're going to dive into religion. This is fun. And this is fun because whether you're religious or not, it's really I always find interest in learning about other people's religion, my own beliefs aside. But, in the Hispanic culture, belief in God healing on his own terms is very, 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 very strong. There's a spiritual and religious influences play a major role in health, illness, and in life. Most Spanish-speaking families, Hispanic families, use primary care as a source of health care, while others may prefer to use home remedies that may consult folk healers like the curandero. And these home remedies are not too uncommon. Sometimes we see them. I'm guilty of some. I was actually wondering, and I'll probably talk about this in a moment, but I was talking to one of my colleagues about I think this I'll get to it in a moment, because you guys are going to think I'm crazy. But there's a hierarchy usually about seeking relief for healthcare, right? We usually start with a home remedy. If I can put some garlic here, some Vicks there. And then we ask relatives, right? We seek out some relatives. Yep, Vicks. I already mentioned it, Miriam. I know. I see you. Vicks. You put Vicks in socks, Vicks in your shirt, Vicks in your armpits. It cures everything. And I'll talk about that in just a moment. But we talk about, so you try a home remedy. You maybe have some garlic and some malanga, something that's going to cure the stomach, cure the heart. And then you go seek some counsel from relatives. Maybe your cousin knows someone who also has this condition. And so you're going to be like, oh, what did you use? And yep, it is like Windex from the Big Fat Greek Wedding. I'm not even joking. I wish we were. And then you seek counsel from your cousins who probably have, this is not good, but probably have saved medication that's probably expired, but they're like, this really worked, so they're going to keep it because they keep it for the purpose of someone else needing it. And lo and behold, you got some ear drops from a cousin. They might seek some like herbal or holistic medications, some massage therapy. They really maybe more of a holistic mindset to healing hearing loss. And then they might seek counsel from an actual a doctor, a medical doctor, and kind of evolve to Western medicine. Now, this is funny, and I didn't know if it goes into, it's not really funny. It is a case, it's an interesting case. And I didn't know where to fit within the religion because it wasn't quite religion, but it really is a testament to how trusting and how believing we are to accepting recommendation from informal sources. It's very common for the Hispanic culture to seek counsel from informal sources. So they're going to get a diagnosis from someone who maybe has a degree to do so, but you best believe that they're going to go ask everybody and their mother who is not degree to do so about their opinion. And they're going to come back with every recommendation saying, well, my cousin thought about this. What do you think? And then you as a provider have to be like, that's a great idea. However, let me tell you why that may or may not work. Because like refuting family decisions is also something that you want to err on the side of caution. You don't want to just disregard what your godmother had to say about their hearing loss, even though godmother may have never worked with somebody with hearing loss, or her opinions are based on the one time she met a deaf man. That this is truly what people are making their opinions on. So in our clinic, we do this unique thing. We actually screen for mental health. We think it's very important in our clinic, especially given COVID. Mental health is huge. I mean, mental health it's triggering for adults right now in this time of a pandemic. And so we actually screen for every child over the age of 12. We screen for depression and anxiety by giving them a screener. And they also have to self-report what their hearing loss is and what devices. And we have obviously an IRB in place where we can screen anybody over the age of 12 with their consent to do so. So this is a patient of mine. She's 15. She does not speak English. They recently came from Cuba when she was 13. So she doesn't know much English. She's in ESOL classes, and she has a cookie bite hearing loss, so mild to moderate, mid-frequency hearing loss, normal in the lows and normal in the highs. She's a pretty good hearing aid user, so to speak. She's one of those school hearing aid users, so maybe 6-7 hours a day, not full-time use, but actually pretty surprising given her age and her hearing loss that she's wearing it actually as much as she is. So I choose my battles with kids. I don't know if you guys take the same approach, but sometimes I'm like, listen, I'll take the 7 hours. I'm not going to push for all waking hour. Like, you are 15, you can make your decisions. I can't staple them on you. And that's when those parents are like, please tell her that she needs to wear it more. And I'm like, I am not her mom. Like, if she's not going to listen to you, why would she listen to me? But I try to, that's kind of when I try to navigate that family experience. I'm like, I know you want me to do it, but they're not going to believe me. Like, they don't believe you. So 15-year-olds are difficult, but we gave her the mental health screener. And what's interesting, and there's probably not enough data that we have collected yet, but what we find is, what I've seen anecdotally is every time I give the mental health screener to someone who has really low wear time, they usually score very elevated on this. I don't think it's a link. Obviously, I don't think they're more depressed due to their lack of hearing aid use, but it's just an interesting anecdotal thought. But I gave her the mental health screener, and when a patient score is elevated, our multidisciplinary team intervenes same day. So we are very adamant, especially if it's a child, that someone is there Monday through Friday, whether it's our social worker or one of our psychologists that'll intervene in person. And by intervene, they just sit and chat with the patient, and they may chat with the parent, and then they warrant at that point if that's going to need routine therapy, or if it was just like she's going through a hard time because of virtual school, we're going to check in with her in 2 weeks just to make sure she's okay. Because an elevated score doesn't mean that it's a diagnosis of depression or anxiety. It just means that they are elevated for their age. And it's just a red flag for us. And if we can, our mentality of administering a mental health screener is if we can catch things in their elevated state, we can maybe avoid things from maybe detrimentally happening to these kids in the future. As we know that there's just obviously an increasing rate of suicide in teenagers, and we want to make sure that we can try and intervene to the best of our capacity, at least with the resources that we have. But needless to say, that's an off tangent for this 15-year-old patient who we default give her the mental health screener, and she scores elevated for both depression and anxiety. And I will tell you, as an audiologist, I felt very, not uncomfortable, but I will say uncomfortable. I'm candid enough to say that it was uncomfortable to talk about this initially, to talk about how, hey, we're administering a mental health questionnaire. I was afraid about what parents would say, like, why are we doing this? I was afraid about the perceptions of what anybody would have to say when we're talking about mental health. And I quickly got over it very quickly when I realized the impact of what we were finding based on making a referral from an elevated mental health screener. We've hopefully intervened on things that could be probably detrimental to somebody's life, and it was all because maybe someone took the effort of reaching out. And that's kind of our mentality. It's just us reaching out. So we were very clear explaining to the parents that this is not a diagnosis, it's a questionnaire about their feelings. They're self-reporting these things. It's not someone forcing them to do it. If they wanted to lie, they could lie. We're not even watching them do the questionnaire. So for a fact that a child is self-reporting these things and they're coming in elevated, to me, is concern enough that probably needs intervention. These kids have no shame. They have no feelings of, they feel comfortable reporting this on a questionnaire. And obviously these are for kids who are literate and can read, and we have it in English and in Spanish. So in our mentality is like, if they're comfortable telling us in a questionnaire, that means it's probably it's in a state where it needs to be addressed. And even if that's just a touch base, like, hey, are you okay? Maybe that's what they're seeking. And that's okay. If they're doing it from an attention standpoint, that's also okay. We'll give them that attention. And if we think that it's just attention that's needed and that's all, that's where we let, obviously not the audiologists take that, but the psychologists who are trained in mental health to do that intervention. But so she did score elevated. I told mom, listen, it's just a check base. The mom was super interested. She was like, oh yeah, we used to see a psychologist in Cuba. And I was like, oh, well, this is probably something. And this is the other thing, like, if they have a diagnosed mental health condition, then obviously they may score elevated, and that's okay too. The mom said that they were previously routinely seeing a psychologist in Cuba, but haven't been able to establish care since they moved to the United States. She didn't know that we had a psychology team, so she was like really excited. And when we asked her, like, why was she seeing, well, when our psychology team asked why she was previously seeing psychology, the mom told the tale of the frog and the blocks. And we're like, what? Oh, we opened a can of worms we did not want to open. Because sometimes we're like, oh, she was seeing a psychologist. This is what I think in my head. This is like very not normal, right? I'm like, she's seeing a psychologist because she has hearing loss and she's struggling with her self-identity as a child with hearing loss. I would say 90% of the time it is unrelated to their hearing loss or their device use. They're like, wait, you're talking about my hearing aids? No, I don't care about that. And I'm like, oh. And part of me is like, should we open this can of worms? Like, did we open a can of worms we didn't mean to open? But we actually find out a lot by this mental health screener, and this is the tale of the frog in the block. So this patient she was seen, mom said, it's like, if you knew her, you would be like, this is strange. But of course, I'm trying to disclose her story in a way that would help you understand what we were thinking when we saw her. So this girl is, aside from her hearing loss, she is clinically overweight. She is technically clinically obese. And so we thought, okay, maybe that has to do a lot with her mental health as well. And lo and behold, mom did disclose that she was seeing psychology and nutritionist in Cuba to get a better hold of her eating habits. But they associated her poor eating habits at the age of 11, 12, due to the fact that something was triggering her. And when you ask her, she says she self-reports of purging. She just purges. She doesn't binge and purge. She just purges. And we asked why, and it was because one day she was convinced that she ate a frog. And ever since that time, she would put food in her mouth and convince herself that she ate a frog, and then she would purge, which is strange. And then it turned into, she convinced herself that she was eating a block, and like a building block, like a block shown in this picture, and then she would purge. And the mom was like, well, that is not normal, not a normal behavior, not a normal eating behavior, not even normal, it's not even a normal eating disorder behavior. It's more of like a pica, like, why are you eating things that are not edible, and why are you thinking that you're eating? And mom's like, I have never seen a frog around our house. I don't even think we have building blocks at home. She's my youngest daughter. She's 12. So it's all of these things that this child was reporting that she thought she was eating, so she would start purging. And it turns out that our team immediately was like, well, this needs a little bit more intervention than what we're able to provide. So investing in the severity of this issue, if she's still purging and she's still thinking that she's psychologically eating something, and assuming that this was out of the realm of a hearing loss, right? This is not even about her hearing loss. The psychology team had asked for previous reports from the psychologist in Cuba, which is really hard to obtain anytime. It's like outside records. And the mom was like, oh, I can't get you those. And we were like, what? Why not? She's like, no, because, oh, the psychologist was actually her neighbor who wasn't a psychologist at all, but knew a person who saw a psychologist for a suspected eating disorder. And we were like, wait a second. So this girl, right? It's almost like laughable. You're like, wait a second, what? But this girl actually hasn't sought out any real like psychological help. And this mom has saying this whole time, no, she was a psychologist for sure. And we're like, no, but give us the documentation. She's like, oh, she's not a real psychologist. She's just like, she knows psychology tactics. So like, and I said, well, we asked her what her recommendation was. And she actually said, if you physically move to a different neighborhood, that she would get better. And they did move, and she didn't get better. So to speak, largely from words of the not wise. This is honestly not that uncommon of seeking counsel from someone who's maybe not qualified to give you that recommendation. But this mom was like telling us as if like she was seeing like state of the art level psychology care team in Cuba. And we were actually pretty impressed because we have many patients who come from Cuba, and we know that the healthcare system is not that great. And that happened to that. So while that doesn't necessarily tie to religion, it does tie to the fact that they'll seek care from any kind of aspect or any avenue, as long as it satisfies their agenda. And so really, if they disagree with your diagnosis, if they're in denial, whatever stage of grief they're in, may navigate them to a different person, or may navigate them to trust you more, depending on how they have accepted what you're counseling them on believing. So that's an interesting case, and trust me, there will be more. But talking about religion will actually tie me into these next two cases. The unfortunate side of this devout faith is that devoutly faithful members can be largely unaccepting of differences in beliefs, lifestyle, sexual orientation, self-identity, and trauma, which can be detrimental to the family reputation. And this probably is true to many cultures, or many cultures who have devoutly faithful members. This is not necessarily just isolated to the Hispanic culture, but because this happened to two patients, we just wanted to highlight them here. So a quick poll before we talk about our cases, and I think this is my first poll. When a teenager gets referred for a threshold ABR, what are your first thoughts? Please select all that apply. There we go.
You have another poll about late appointments too.
Oh yeah, we'll get there.
Okay.
That'll be a fun one. Nice. Interesting results here. So about 40 of 45, the majority of you said that usually your first thoughts are that they may be special needs and not understand the task, quickly followed by they're difficult to test, and then also followed by malingering hearing loss, and then not wanting to participate or seeking attention, or a combination of those, I would imagine. Thank you guys for sharing that. That was really great. Yes, ANSD may be another reason if they have inconsistent thresholds. Now, for sure, I think I would probably, yeah, I want to say that maybe reflexively, I would be like, oh, is she a malingerer? And then I'm like, well, maybe not a malingerer. Let's give them the benefit of the doubt. So I always try to be like, so true to how the results show, I'm going to give them the benefit of the doubt and be like, they don't understand the task, they need a threshold ABR. But I'm going to tell you a tale of two patients that we saw, and they had very, very similar. I saw them probably within 3 weeks of each other, so it was very telling. I was like, "Oof, what's happening here?" And this information was really tied to religion, devout faith. But both of these are females, and they entered our clinic for an audio, and both of them presented with severe to profound hearing loss with conventional audiometry. They're both 15 and 16 years old. They both held conversations without visual cues, which is a red flag, obviously, to any audiologist who you're like, how are you not responding, but you're talking to me perfectly fine, and I'm not even looking at you. One patient reported debilitating tinnitus, while the other one reported debilitating hearing loss. They both were fit with amplification at an outside clinic, which makes me so nervous. And we see this a lot. We're like, oh boy, what are these hearing aids set to? Yikes. And patient 1 had her hearing aids were programmed to a moderate loss, while patient 2 were programmed to a severe to profound loss, which is a yikes situation if the girl is talking to you without any visual cues, without her hearing aids on. They both referred for threshold ABRs. Both of them willingly participated in the ABR. I didn't need to psychologically tell them what they, sometimes I feel like sometimes, I don't know if anyone else has felt this way, but sometimes I'm like, I'm not going to tell them too much because then they're going to like start wiggling. And if they're malingering, they're going to do it on purpose. And I always get into my head and I'm like, you know what? I'm just going to tell them they need to close their eyes and just relax. It's the easiest test that they could ever do. And that actually ends up faring much better than me trying to be like, you see, if you move, you're going to mess up my testing. Like, why would I ever say that? That's so silly. So they both end up participating fine for the ABR. Patient 1 has a normal ABR from 5 through 4. Patient 2 has normal ABR from 5 to 2 with a mild hearing loss at 4,000 hertz. Patient 1 has present and robust DPOAEs bilaterally. Patient 2 has present and robust from 15 to 3 and absent from 4 to 6. Oops. They both failed the mental health screening, and they both were subsequently diagnosed with a conversion disorder by our psychology team, which is, if anyone knows what a conversion disorder is, it's the belief that you have something that is not actually diagnosed. It's not an actual diagnosis, but it's you have psychologically convinced yourself that you believe that you have this. So some people with conversion disorders may actually believe that they are blind. In this case, these girls actually believed that they had hearing loss. And the way we found that out, and in fact, actually patient 2, side note, had her hearing loss. She had a previous audio. She had a previous audiogram that had present and robust OEEs at all frequencies, which suggests that likely her hearing aids are causing this, what I presume, a noise-induced hearing loss, because she had a notch hearing loss in her ABR, and she now no longer has OEEs at those frequencies that are highly affected by noise exposure. And she's wearing her hearing aids 15 hours a day. I don't know how, like that girl has some tolerance, but they were a Resound Enzos programmed to a severe to profound hearing loss. And while I want to shame the audiologist who fit her, that's not why we're here today. We're talking about what's really going wrong with her, because in the end of the day, we need to figure out what's happening with these children and what's happened. And this is, right, we're talking culturally what's happening. So this is not an audiology lecture by any means, but patient 1, so this is the one who reported debilitating tinnitus, unfortunately, was transitioning from being a female to a male. In the process of transitioning, she explained to her family about that she wanted to transition, and her mom actually reported in the appointment that she sought out spiritual cleansing for her daughter. Her daughter, who was the patient, self-reported it as an exorcism. What happened in her experience, we don't know, we weren't there, but she described it as her naked body was on the table and she was being thrown holy water at her to cleanse her. And she doesn't have this relationship with her mom, but her mom brings her to the appointment. They don't talk to each other. Clearly, she failed her mental health screener. She was very calm and relaxed about anything, and actually told the story with ease. And her name, she just didn't, she didn't know what to do, and so she actually disclosed that she is seeking hearing loss because she knows that she'd get better treatment with a hearing loss than being transgender, and that she could probably get her resources through another clinic. And so she researched our clinic. She knew that she could get help through a multidisciplinary team within our clinic. And so she outsourced this problem, and she was subsequently obviously diagnosed with a conversion disorder. And our team really had to work diligently to telling people, like, she doesn't have a hearing loss, but she does need help. Obviously she needs to seek counsel, her family needs to seek counsel, whatever the case may be. The next patient, unfortunately, also related to more less religion and more protecting the reputation of a family. This patient was from the Dominican Republic and was unfortunately sexually assaulted by one of her family members continuously. And she faked her hearing loss, was well aware she was faking her hearing loss until the point that she actually believed she had a hearing loss, and thought that the only place that could give her good care was actually in the United States. So her family moved her to the United States where she can live with US relatives while she was getting treatment for her hearing loss, until we finally disclosed that she didn't have a hearing loss. And then she disclosed everything that was happening to her. And she said that the only way that she could seek refuge from what was happening to her physically was to convince herself that she had a hearing loss so much that she would tolerate her hearing aids, to a point that like she almost went from she knew that she was malingering, all the point that she convinced herself, so she wasn't even flinching wearing these profound hearing aids. She would put them on reflexively, like, oh, let me put on my hearing aids, I can't hear you. And our psychologist had to really talk to her and say, like, you are causing a hearing loss with your hearing aids, and we really need to get down to the root of what happened. And the uncle, who is the US resident, said, it's a shame because her family sided with maintaining the reputation instead of seeking help for her, because she was getting sexually assaulted by a family member. They didn't want that to be exposed, or that to be a part of the reputation of their family. So they protected their reputation instead of seeking help for her, because one was going to compromise the other. And unfortunately, that happened with her. She is still living in the United States. She's not wearing her hearing aids anymore. We did get her hearing aids that appropriately fit her hearing loss, and she's getting routine help from our psychology team. But, these are just kind of extreme situations, but are real cases that actually patients we see who, you think of, you're like, wow, this, I would never, as an audiologist, I never thought that I would encounter this case of a girl who's transitioning and is struggling so much that she's pretending to have a hearing loss, but has convinced herself that she's had a hearing loss, all because culturally she's not accepted by her own family, who is seeking to spiritually cleanse her of her sins, essentially. And she's very well aware. She's cognitively aware of what's happening, and she just is like, I can't control who I am as a person. And so very interesting kind of case points about this case specifically. Religion, oftentimes medications are often shared with social networks. I talked about before, you may reach out to a cousin who had an ear infection and be like, oh, didn't Billy have an ear infection? And that cousin will be like, yeah, I have those drops still. Do you want to use them? And like, well, that's definitely not sanitary. It definitely happens. But sick people in the Hispanic culture may simultaneously use a whole lot of things. They may pray, they make use of folk herbal medicine, a prescription from a friend, and use Western medicine at the same time. So it's not always that they're resistant to medication, but they may be using a combination of sorts to find um, their kind of their niche. So, diagnosis and counseling. This is important. The quality of care and diagnosis perception is often deemed dependent on several factors, such as the perception of genuine concern. So they want to make sure this is a serious thing. Inclusion of family in discussion and diagnosis. We talked about this before, including the entire family when making a diagnosis. And use of patient's native language. All of these things were driving factors into how important this was for families. Like we mentioned before, these families are likely to obtain information from informal sources like the psychologist who wasn't a psychologist in Cuba, and will like to seek counsel with other members. So managing a diagnosis, we have, I'm sure we're all familiar with the 5 stages of grief, denial, anger, bargaining, depression, and acceptance. And it's said to believe that oftentimes Hispanic families specifically bounce from one to the other and don't go in any specific order. They may actually reach the acceptance phase and then actually revert back to another phase, depending on several factors. So they may not actually, the trajectory may not be as standard as we expect it to be. I'll briefly talk about folk illnesses because this happens a lot in the Hispanic culture. They believe that certain things can happen that are may not really are diagnosable, such as humoral imbalances. Things that cause hot and wet things like blood need to be cured by cold and dry things. So, for example, cold and wet being phlegm needs to be cured by something hot and dry. So it's a very kind of, you need to find the balance within yourself, within the environment to heal. Another one is empacho, which is illness related to resulting from a dislocation of different parts of the body. Your upset stomach due to eating the wrong food at the wrong time, undercooked food, or swallowing gum. And the cure is rubbing your stomach or your back with cooking oil and then pinching your spine. It's a common cure. Envidia, this is a funny one. It's envy, causes illness and bad luck, and there is no cure for that. Oh, no way. You better not be envious of anyone because that will get you. That's a lifelong condition for sure. Um, we also have the mal de ojo. This is something that's very true, at least in the Cuban culture. Whew, the evil eye caused when somebody looks in admiration or jealousy at you, or it's usually either at you or your child. So oftentimes you want to protect your children from the mal de ojo. And you can do that by two ways. You say a prayer while passing an egg on their bed and placing the egg in a bowl under their bed overnight. Or you use what's more commonly used is un azabache, which is a little bead attached to a little, it's a pin often. Sometimes people can wear it on a bracelet. It's a pin that's usually pinned to the back of a baby's onesie because usually the mal de ojo, which is the evil eye, is looking at them from the back, like from behind. So they have the azabache to protect them. And listen, I have many friends. I think I have cousins who are using azabaches. I actually just recently was cleaning out my closet and I found my azabache that my parents used. They're devout people, religious or not, believe in the evil eye and its powers and how to remediate it. And then susto, which in Spanish just translates to fright, is an actual Megan, you said, does this mean fawning over a child's appearance or how cute they are can make it? Yes, absolutely. Um, 100, like being overzealous about it can make them uncomfortable. Like, oh, thank you. That's enough. Like, you don't need to keep admiring my child. Because that's a very common thing. Like, oh, how cute. I want to touch him. I want to squeeze him. Yeah, that can cause discomfort. And often it's usually the mal de ojo is not, it may not come from a malicious standpoint. It could be just a point of admiration. And so, yes, over admiring a child may cause them to elicit these remedies to make sure that they're protecting their child. They may not have any bad feelings towards you, but they're just like, I'm protecting my kid just in case this actually happens. Yes, some people use safety pins in lieu of azabaches too. And then susto, which actually means fright in Spanish, it's the fright sickness arising from a traumatic or frightening experiencing, causing your soul loss, where your soul leaves your body and wanders freely. A lot of times these are kind of common alternative treatments that I've been presented to by parents. Like, hey, do you think this would work? This is some like Chinese medicine off Amazon. It doesn't work. Surprise. I've had a parents put goat's milk in a child's ear. Also did not work, but it was recommended by their priest. Vicks. Listen, Vicks works for a lot of things, but it does not cure hearing loss. So do not put Vicks in the ear. I can imagine that hurts. It hurts when you put it up my nose. So I can imagine like in the ear is not fun. And the beads. Ooh, okay. So in their most extreme forms, this is actually Santeria beads. And while Santeria makes people uncomfortable, I just saw Miriam's face. It is actually something that we should shed light on because it could be something that you may experience in your clinic. In fact, our clinical fellow, his first day with me, I had a patient who practices Santeria, and you would know that they practice Santeria, or at least they're in their first year of sacrificing themselves to Santeria because they wear all white and they wear these decorative beads inside their shirt. It was developed in the 16th to 19th centuries by the Afro-Cubans during the slave trade. The slaves came in and they pretended their gods were religious gods as well in order to keep their faith. So in order to convince that they could still practice their faith, they convinced the Cubans that these gods are real gods too. They're also saints and they're also spirits that we should be praying to. And it's actually believed that nearly 50% of Cubans living in Cuba now actually practice a blend of some Santeria and Catholicism. Santeria in itself defines personal relationships through divination, sacrifice, initiation, and mediumship between practitioners of the religion and the Orisha deities. Orishas are different gods. They are gods for everything. There's a god for the rain, there's a god for thunder, there's a god for luck, there's a god for everything. And these gods provide their devotees with protection, wisdom, and success, and to those who guide the devotees in times of crisis. A common response to ailments for Santeria's healers is to prescribe spiritual cleansing. And many santeros and santeros oversee a healing ritual called santiguo, which means to bless or to heal by blessing. And this is particularly used for children. So when we talk about sacrifice, I've actually had many patients who have sacrificed their children. And I don't mean this is like sacrificing their lives, but they bless their children into the realm of Santeria. So their children become Santeros, but this is because they want to heal them or to bless them. So they give the Orishas a child who is supposed to be pure, and in return, the Orishas cure the child of whatever ailment they have. So I've seen parents and children as young as probably like 7 wearing all white in our clinic, and you just being aware. There's a lot of skepticism behind Santeria too. You don't want to, a lot of, informally, you wouldn't ever want to cross somebody who practices Santeria. A lot of times it's associated with voodoo or like black magic. There's a lot of sacrificial things. They sacrifice chicken heads, and you might see chicken heads, or if you see eggs at your house, or by the stop sign, you may see the 3 eggs on your stop sign. It's like very kind of weird traditional things that happen more frequently, obviously, in the Cuban culture, but something to just remember, something probably more prevalent in my clinic than yours, but still there. And etiquette. So Spanish speakers use varied degrees of formality depending on who or what the circumstances pertain to. A kiss on the cheek is common as greeting for strangers. It's usually from woman to woman or men to woman, like I mentioned before. Language formalities exist as well, such as tú versus usted versus vos. They all mean you, but when you use them is really important, and we'll talk about that later. And in non-formal settings, conversations can be loud, fast, adorned with animation, gestures, hands. I talk like this all the time. I am very much an adorned Hispanic person who speaks very loudly. And Hispanic people tend to be more relaxed and flexible about time and punctuality more than non-Hispanic people. Not being on time is socially acceptable behavior. So another poll here. How do you guys handle late appointments in your clinic? If Becky, if you want to pull up that poll. Do you allow patient 1 late appointment? A late policy is half of the appointment time, so 30 minutes for 1 hour. The late policy is 10 to 15 minutes, no matter what. We don't have a late policy. The patient's eventually seen. Other policy, if you want to share. So it looks like the majority don't have late policies, and bless you people, woof, that not having late policies, because let me tell you that if we didn't have a late policy, I'd be working until 9 p.m. That's for sure. And the reason is because a lot of times, I don't know how else to do this, but the Hispanic people don't have any shame in showing up late, right? So it's actually one of our fellows came to our clinic, and he's like, I have never seen someone just willingly show up 50 minutes late. Like, if they're going to be late, they're either going to be late and it's going to be like 10 minutes, or like I show up 50 minutes late for my hour-long appointment and they think it's okay. And it's like, it's such a social and cultural understanding of like, they will show up, it'll be late, and it's not that they don't care, but it's just normal for them. So really having a point of like education with that, and talking about like when is it appropriate to be late and when it is not appropriate to be late is really, really, really important. I'm actually going to skip this video in a lieu of time, but it is a video of Sofia Vergara in Modern Family talking to Jay, her husband, who is a white Caucasian male, and he's complaining to her about why she's always late. And she's saying, well, I want to make a scene. Duh, like I want to make an entrance. And then she proceeds to make her entrance, and it's actually really funny. But we have 9 minutes left, so I'm going to go over a case in the next 2 minutes, and I'll give you guys about probably like no more than 5 minutes to review it, because then it'll be lunchtime, okay? So we have a 4-year-old female with bilateral cochlear implants. She actually has the AB Ultra devices. If you guys know, there is an AB recall. If you don't know, now you know there is an AB recall. And so she was diagnosed with progressive hearing loss. She lost her hearing at age 2 and progressively became bilaterally profound after 6 to 7 months of her diagnosis. So she lost her hearing pretty quickly. She was sequentially implanted at 3 and 3.5 years old. She also has a family history of hearing loss. Her older sister is bilaterally implanted. So now this family has 4 implants in the family. Current day, she has very few words. Her device use is pretty poor, around 5 hours a day. Her sister is nonverbal and uses more gestures and attempts at speaking. While she reflexively will put her coil on her head, she's never really deliberately asked for her cochlear implant. If it falls off her head, it'll stay off her head. She's not someone to be like, oh, I want it. She's not the type of kid that wakes up in the morning and she's like, give me my implants, okay? Her mother received a letter from AB about the recent recall, and mom is thrilled. She's so excited. She's associating this with a potential miracle that she has been waiting for. So after extensive testing, it was concluded that both of her implants were actually compromised and needed to be revised. The girl's not hearing optimally with these implants, and she needs to have a bilateral revision. And the family seemed to be on board with the decision when we immediately told them. However, the mom called the day before the surgery, and she explained that her belief is that this was God's sign that he was going to spontaneously recover her hearing, that this was the first step in recovering her hearing. And so we're going to break out for no more than 5 minutes, okay? And I want you guys in your groups to describe what state of grief this family is in, if any, if you think any, and how would you counsel this family, and what is your plan? And I think Becky will conclude,
You'll have a 30-second warning when the rooms close, and this will put you automatically in a room and bring you automatically back.
great.
Hey, I put you in a room with me.
Okay, I was like, oh, I got sent to a room.
No, I had you in a room, but then I made a room that was just you, and then I join it.
Perfect.
As the host. So I think, I mean, you've got some interaction and some people smiling and laughing.
Yeah.
And
I do like frequent camera checks because I'm like, I'm not alone, right? And I like, and people are nodding their heads.
No. And people are letting me know when they're stepping out and when
Which
they're
is
not.
great.
Yeah, it is.
Yeah, and this is actually the last thing because then it's just the end, like what we talked about, and then it's lunch break.
Yeah, so it works out good.
I'm actually happy that this
gives them a break.
Yeah, for sure.
And it's my earphones that are the problem.
Oh, okay. Well, that's good to know.
Because they have wax in them.
Oh no.
And I just need new headphones.
So overall, you think it's going well?
Oh, I think it's great. And
Yay.
Sarah's session is going well too, because I checked with Jill.
Good, I'm happy.
I think it's going well.
This time is going by so fast. I could be talking about my stories and case examples forever, and I'm like, I need to hone it in and keep going.
Yeah, because they want something practical. I want them to go home. I want, what's this look like at work tomorrow or on Monday?
Yeah, absolutely. Well, I'm excited to see what they say about this case because she's
out when you fix your microphone. Okay, I need to leave and go help Emily.
No problem.
Okay,
I'm here.
Did it kick you out again?
Yes, but I think now I'm back in it.
Maybe. No, you're not.
Oh,
I'm going to move you to.
I think I was in 6.
Ooh, everyone's trickling their way back in.
It actually sends everybody back into the room automatically. There's some settings that you
That's
can
cool.
use now. Yeah, it is. It puts them in there so it doesn't pop up and say join this meeting. So it really doesn't give people a choice but to go into a breakout room.
Yeah, I got sent to the room by myself until you joined, Becky. I
I
was like,
put
oh,
you
where
in
am
a
I
room
going?
by yourself on purpose.
And then it was like my face. I was like, whoa,
Oh, well, if
scared
you
me.
want to let me know if you want to be in a room
Oh, no,
next
it's
time.
fine.
Okay.
Not a
all right.
problem.
Okay. All right. Chrissy, you want to finish up and then we'll go
Yeah.
to lunch.
So I will maybe take some feedback from maybe one or two groups. If anyone wants to take a mic and ask what kind of your thoughts on this case. Anyone want to take some? Anyone? Raise your hand if you would like to speak on behalf of what your group decided.
Or type in chat if you want to share.
Okay, I'll be brave. I'll talk.
Oh, all right, Brooke.
Okay, go, Brooke.
It's funny because I can't see myself, so I'm hoping you can see me.
Yes.
Anywho, we decided, obviously this family's in denial, and that we would obviously respect, their cultural decision, but try to give as much education as probably that has been already said beforehand. That it's very important that we, continue with activation or reimplant because they've had this done before, atrophy of the brain, speech and language, all of those things. And then also throw in there that maybe, if not listening to us, sorry, my dog is coming over here to say hi. If we weren't the ones that could talk to her, maybe there would be some other outside resources to help, family and educate them to help them get through the stages of what's going on with them right now. So.
For sure. Thank you so much. Yeah, and Amy, you're commenting. I guess I'll read your chat out loud. You said that she's in denial and the parent needs, hold on, I'm scrolling the other way. The parent needs counseling, realistic expectations, regardless of what they choose to do. Amen. That's definitely for sure. I kind of struggled with, I didn't know what stage of grief they were in. I found it hard to believe that she was in denial, given that her other daughter is implanted. And I actually asked her, I had to confront her. And sometimes confrontation is needed when you can get real with them and say, well, why isn't this miracle happening for your daughter? And she was like, you're right. I don't know. And I was like, I'm not trying to make her not use her daughter's implants, but she comes to her daughter's appointments just fine. And so it's just an interesting case. I did kind of make you food for thought. And the result is that we're still waiting for them to, come back and see if we can continue talking about, what she's seen, because she says with time it's going to happen, and we're trying to just give her the time that she needs to process what's happening. But that was the end of my section. It's lunchtime. We're 1 minute over. I don't want to take any away from your lunch break, so I really appreciate you guys being engaged till the last minute, and we will reconvene at 1:45, right?
Right. Okay, we'll see you at 1:45.
Bye,
at
everybody.
12:45.
Oh, I'm so sorry. 1:45 for me. Oh my gosh, I'm so sorry. 12:45 for you guys.
Same
oh my
place.
gosh.
Yeah,
Can we come back? Can we come back to this one?
Yes.
Yes, you'll come back to this room.
Mm-hmm.
Thank
Okay.
you. 12:45. Sorry about that. Bye.
Chrissy, enjoy your lunch.
Thank you.
Hey, Chrissy. Oh, she just logged off.
Oh yeah, I'm here. What's up?